Hello and welcome to the Parkinson's Foundation Wellness Wednesday program, and happy holidays. I am Sarah Osborne, a program manager for the West region of the Parkinson's Foundation. Joining me today from the Parkinson's Foundation Community Engagement Team are Nancy Nealon and Danielle Agpalo. Thank you for joining Supportive and Palliative Care, the best kept secret in medicine. So I'm tuning in from Los Angeles, California, and we'd love to know where you're tuning in from. So the chat is open. You can go ahead and feel free to share your location in the chat if you're in Zoom, or if you're watching from Facebook Live, you can go ahead and tell us where you're tuning in from in the comments section. Awesome, lots of responses. So Pennsylvania, Washington, New York, Georgia, wow, Oregon. That's fantastic. New York, Boston, yep. Thank you so much for joining us today. So the Parkinson's Foundation will be hosting virtual events each Monday, Wednesday, and Friday, starting again in the new year. And to learn more about these programs, you can go ahead and visit us at parkinson.org/pdhealth. PD Health at Home is presented by the Light of Day Foundation, whose generosity has made this program possible. Thank you to the Light of Day Foundation for their support. The Parkinson's Foundation provides families with free resources, including our website, which is parkinson.org, our educational book series, our webinars, podcasts, and our hospital safety kit called Aware and Care, as well as our toll-free helpline 1-800-4PD-INFO, which is staffed by Parkinson's specialists. So to learn more about our resources and our upcoming virtual events, remember to visit that website or to call that helpline. Okay. So before we get started and before I introduce our guest speaker today, I wanted to quickly poll the audience. So again, if you're joining on Facebook Live, feel free to answer these questions in the chat. The first poll reads, palliative care and hospice are essentially the same thing. True or false? Palliative care and hospice are essentially the same thing. True or false? So we have a lot of responses coming in, mostly false so far. Great, so you can see here the results. 84% said that that is false. So one more quick poll. The second poll reads, palliative care is for later, more progressed stages of chronic diseases. So that's also true or false. Palliative care is for later, more progressed stages of chronic diseases. About half and half right now. Great. Great, so we're about split on that answer. So thank you everyone for sharing and participating in that. So without further ado, I'm excited to welcome our guest speaker, Dr. Benzi Kluger. Benzi Kluger, MD, MS, FAAN, completed his residency in neurology at the University of Colorado, Denver, and fellowships in behavioral neurology and movement disorders at the University of Florida College of Medicine. He's been a pioneer in neuropalliative care, a field dedicated to the radical idea that improving the lives of persons affected by neurological illness requires seeing and treating them as whole people. Dr. Kluger created one of the first team-based neuropalliative care clinics in the world at the University of Colorado. He has published numerous papers important to the growth of this field. His research focuses on neuropalliative care, fatigue, and neurodegenerative illnesses like Parkinson's disease, with some brief excursions into other areas like nutrition, acupuncture, and cannabis. He's currently a professor of neurology and medicine and the founding director of the Palliative Care Research Center and Neuropalliative Care Division at the University of Rochester. So thank you, and with that, I will hand it over to Dr. Kluger.
All right. Thank you all for attending, and seems like based on the poll results that we have a sophisticated audience here today. I'm going to pull up my slides in a second, and I think the way that things will work is that if during the talk, if you have ideas or comments or questions, please share those during the chat. And at the end, I'm hoping to have 10 or 15 minutes that we can go over things and have more of a lively discussion. So I'm going to go ahead and share my slides here. we go. Okay, so we'll talk about neuropalliative care, and I'll come back around this to the end, but this has been a growing field, and we are looking for people living with neurologic illnesses, including Parkinson's, and care partners and families to be part of our society. That it's not just who we serve, but I think who we are. So we'll talk about that a little bit more at the end. I have received grant funding for this work. And this is really just to show that there is a lot of interest from a lot of people in bringing palliative care to more people and going beyond cancer. My objectives for this talk are first to define what we mean by palliative care and neuropalliative care, which is a newer term. Second, to understand why neuropalliative care is really essential to achieving the best outcomes possible for people living with neurologic illnesses like Parkinson's. We'll talk about what the basic components of neuropalliative care are in part so that you can help make your doctor a better doctor and get them to do more palliative care than they may currently be doing. And lastly, for those of you in the audience who are advocates, either on a policy level, on a local level with clinics and support groups, perhaps being an advocate for people that you love who are living with Parkinson's, I'd love it if neuropalliative care became part of what you shared and talked to people about. So defining neuropalliative care, this I think is probably the most succinct and accurate definition that I know of. It's from a friend of mine, Steve Pantelot, who runs the palliative care program at the University of California, San Francisco. Palliative care is about living as well as possible for as long as possible. And I really stress living as opposed to surviving. So it's not about surviving for as long as possible, although it actually may increase life expectancy. It's really about living and living in a way that makes you feel fully alive. The World Health Organization has recently updated their definition of palliative care, and I'll call to attention a few things. So first of all, it is about enhancing quality of life. And an example from that from my clinic in Colorado, a couple was we had a woman with multiple sclerosis. She was in her 40s. It was very advanced. She was wheelchair bound. And our clinic social worker helped her to get connected with a group that did skydiving for people who had quadriplegia. We have helped people to modify their RVs to be handicapped accessible. We are frequently encouraging people to do more of what they love doing, to connect to people that they love, to find meaning. So that's really a core part of palliative care, and I think it surprises some people. It's about offering support to help patients live as actively as possible. And it also is about offering support to family members, that the palliative care model doesn't just focus on one person, because we know neurologic illnesses like Parkinson's don't just affect one person. Palliative care can help provide relief from pain, from fatigue, constipation, other distressing symptoms. In research that I'll share later, we've shown that the palliative care approach actually does a better job of that than routine care. We affirm life and regard dying as a normal process. And I put that up there. I sometimes will have a slide that shows the world mortality rate, which has been stable at 100% for a pretty long time and is probably going to stay at 100%. And it may sound silly, but I think a lot of conversations that you hear in the hospital, it seems as if the US healthcare system believes that death is optional. And death is not optional, unfortunately, and decline in an illness like Parkinson's is also not optional. What is optional is how we die. And I think for most people, dying in the hospital, dying coming in and out of hospitals or in a nursing home is not how they would want to die. And so by having open and honest discussions about progression, about end of life, it allows people more control over that process and allows them to make better decisions and do things that they don't regret. The other thing that I'll say now and probably repeat later is that palliative care, when it's been studied, and this includes several studies now in cancer, is actually associated with a longer length of life. And in our study in Parkinson's was actually associated with better motor function and better movement. And I think the reason for that is that going in and out of the hospital is dangerous. and that when people are really able to live fully and connect to their family, be at home, and their values, that they live longer and that they do better. We address psychosocial and spiritual issues, and there's a difference between a psychiatric disease like anxiety or depression and a psychosocial issue like grief, which is a sense of loss for how your life is different now or maybe different in the future from what you wanted it to be, or spiritual issues like feeling demoralized or feeling hopeless. Those are things that we can help with. Lastly, and this goes to one of the quiz questions, is that it's applicable throughout the whole course of an illness. So it is applicable for people with advanced disease, but also for people even at the time of diagnosis. And what we found in our research, and others have as well, is that the time of diagnosis actually can be a very stressful time for people with Parkinson's and their families, in a time where they really could use an extra layer of support. We're also at Colorado, had started a program and are starting one here of pairing palliative care with deep brain stimulation surgery. Again, the idea being is that that's a time where people living with Parkinson's and their families could use an extra layer of support. The term palliative care is sometimes confusing because we use it to mean a few different things. We sometimes use it to mean an approach and a philosophy of care. We'll use the term in medicine of primary palliative care, which is palliative care skills that every doctor, every nurse, every person in healthcare should have. And I would say that it's a very person-centered philosophy of care. Palliative care is a skill set. It includes having difficult or challenging conversations with compassion. It includes being able to discuss prognosis in a way that's meaningful and provides people a roadmap. It includes managing symptoms like pain. Palliative care is a specialty. There are people who go through palliative medicine fellowships, but you don't necessarily need a palliative medicine specialist to get palliative care. And in fact, if we depended on palliative medicine specialists to provide all the palliative care that people with Parkinson's needed, we would not get very far because there are not enough palliative medicine specialists. Palliative care is also a public health goal. So we want people to be able to die at home, to die with dignity, to be comfortable with incurable illnesses, to maximize their quality of life and what they're able to do. And all of those things really tie into this core philosophy of palliative care. Kirk Hall, who is an amazing patient friend of mine, advocate, wrote a paper on palliative care from a patient point of view. And one of the ideas that he came up with that I really love is thinking about palliative care as a three-legged stool. That if we think about palliative care as a goal that we have, namely that we want to maximize the quality of life of patients and their care partners, that we need palliative care specialists who understand Parkinson's. We need community and disease support organizations like the Parkinson's Foundation to incorporate palliative care in their message. And we need primary care providers and non-palliative specialists like neurologists to adopt and use the palliative care skill set as they're caring for patients. And if we don't have strong legs for all of those legs, we're not going to meet our goal for the most people possible. Palliative care complements our current model of care. So it's not an either or kind of thing, it's a both and. So in our current chronic care model, there's a focus on disease-related medical symptoms, things like tremor. There's a focus on improving physical health, on prolonging life. Focus is on the patient. And we'll bring in other people on the team like physical therapy when needed. Palliative care, in contrast, focuses on the total pain of having a serious illness like Parkinson's. So that doesn't just mean medical symptoms, but also physical challenges, psychosocial issues, spiritual issues, and practical challenges, such as getting help at home, completing paperwork, having a backup plan to plan for the future. It's focused not just on physical health, but overall well-being and reducing suffering. And so there is still joy to be found, even in the midst of a serious illness. And in fact, I think joy may be even more important to try to find during tough times. We affirm and value life while planning for inevitable decline. And so I think it's an area where we can have very honest and explicit, but also compassionate conversations. We focus on not just the patient, but people living with illness and their family. And we almost always will use an interdisciplinary approach because there are so many aspects to this, that I'm not a social worker, I'm not a chaplain, I'm not a counselor, and we need help to take care of people with all of the issues that come up with these illnesses. Palliative care is not the same as hospice, and I think most people got that correct. Hospice is part of palliative care, and in the United States, hospice is the part of palliative care that is concerned with people nearing the end of life. But palliative care, as this general approach, really can start at the time of diagnosis. Palliative care is not euthanasia or death squads. If people want to talk about death with dignity and medical aid in dying, we can. The palliative care community is actually split on whether or not to support death with dignity and other things like that. I can share my experience working with that program in Colorado, where there was a medical aid in dying law. Palliative care is absolutely not giving up on patients or doing nothing. I think that comes from some language that we unfortunately use, where we might have somebody in the emergency department and we ask them if we want to do everything for them. I think the real question is, do we want to do everything for them to survive as long as possible, or do we want to do everything to keep them comfortable? Do we want to do everything to keep them at home? And with palliative care, we provide intense, aggressive treatments, but the goal is not necessarily that people can survive as many minutes as possible, but really that they can live as many days as possible, and to work really hard to allow people to stay at home, to be comfortable, to spend time with their family. And it's not just for people who are dying, not just for people with cancer. And it's an important distinction, is that it's not just for palliative care specialists. This is for everybody on the healthcare team. So what is neuropalliative care? So this is an approach to care that incorporates palliative care and recognizes that people living with neurologic illness have needs that are unique and that are very different in a lot of cases from people living with cancer, as just one example. The recipe for comprehensive neuropalliative care, and for where I would love to see the Parkinson's field, is that we need to have palliative care doctors who really understand neurologic conditions and treatments, and neurologists who feel comfortable with the palliative care approach and can share their knowledge in a way that's helpful and compassionate. We need to have supportive teams and systems and institutions. There's definitely a lot of advocacy that can be done around this in terms of how healthcare is paid for, in terms of how things like hospice are rolled out, which was really developed for people with cancer more so than Parkinson's. So there's a huge role right now for trying to update these things to incorporate people with Parkinson's, Alzheimer's, and other neurologic illnesses. We need to have outstanding communication between all members of the team and with the patient and the family. And that we need to mix well. So it's not going to work well as a system if we just add one more doctor to your team who's not talking to the rest of your doctors, and then we end up with something that's maybe even more of a hassle and more disjointed. And so we really need to think about, as far as models of care, of how can we make this automatic and embedded and integrated and hybrid with the care that we're currently providing. So when I bring up palliative care with patients, and when I bring up palliative care with physicians, I'm careful about the language that I use. There have been a number of studies that show that patients are more likely to go to a supportive care clinic than a palliative care clinic. And in my experience, physicians are more likely to refer patients to a supportive care clinic than a palliative care clinic. The point here is that healthcare providers also have some misunderstandings, at least some do, about what palliative care is and what its role is for Parkinson's disease. It's important, if you are involving palliative care, that your family and that your other healthcare providers know why you're requesting this referral. I think it's important for family because a lot of times family, when they hear that mom decided that she wanted to go to hospice, they hear that as mom is giving up. And the truth may be that mom was not giving up. Mom was just sick and tired of going to hospitals, and mom wanted extra support to try to stay at home and to be comfortable. Similarly, for healthcare providers, it's important that they know what your goals are and what your wishes are with palliative care. These are phrases that you could use if you're interested in trying to get palliative care, and we'll talk more about what that may provide you. But I think me and my family could benefit from an extra layer of support. I would like some help talking about the big picture and developing a roadmap for the future. I'm struggling with grief or pain or fatigue, and I believe a palliative care specialist may help. And I bring this up because when I've given this talk before, people will often ask me, how can I get palliative care? And then when I follow up with those people later, sometimes they would say, I asked my doctor about it, and he told me it wasn't time to do palliative care. And so I want to, just anticipate some of the difficulties that may come up. Neuropalliative care is essential for Parkinson's disease. This is a quote from Elena Sumrall, who is a care partner whose husband died of Lewy body dementia and who I work with. I was actually her husband's doctor, and she has continued to work with me in our clinics as a volunteer. I see such a sense of relief on the faces of patients and care partners when they realize what is available to them through palliative care. They know they have a team to help them, they feel their symptoms are better addressed, and their concerns are heard. And Milena would know this intimately because of her own experience and because she is now a volunteer and a peer navigator who helps other care partners through the system. When I talk to people in my clinic and outside of it with serious illnesses like Parkinson's, these are the things that really matter to people. And if I'm missing something, definitely let me know, but it's family, being able to spend time with family, knowing that their family is going to be supported no matter what, that they're not going to be a burden to them. Integrity and dignity, so that even though somebody has an illness like this, that they are still an asset to the world and that they still have control and choices in their life. Having a roadmap for the future, knowing where they are on that map and what's ahead. I've heard so many people feel before palliative care that they were just moving one day at a time in the dark and had no idea what to expect. Having adequate symptom control. We know from studies that when it comes to things like pain and depression and constipation, that those symptoms often fall between the cracks, that neither the primary care doctor nor the neurologist are addressing them. Lastly is joy. And this might be surprising to some people to see on this list, but when we've done studies of people with Parkinson's and we asked them what's the most important thing to them over the last 3 days, over half of their responses were positive. And so I think it's really important that we recognize that life does not end with Parkinson's disease, that joy does not end, that love, connections, and meaning do not end, and that as individuals and as a healthcare community, we need to continue to focus on that and allow people to live right up until the time that they die. Some palliative care issues that come up frequently in neurology and in Parkinson's are non-motor symptoms, things like pain and fatigue and depression. Demoralization or hopelessness is very common in neurology, I think more so than cancer, because people with cancer feel like their chemotherapy might work, but very few people have the sense that their Parkinson's is going to go away. Other spiritual challenges that come up is people feel that they're being punished by God, that they have a challenge to their faith by having this illness. There are very high caregiver or care partner demands, and there can be a high level of burden with certain illnesses. There's a lot of variability and complexity in prognosis, so really trying to have a crystal ball of what to expect next year or even next week. End-of-life care is something that, as in general, we don't do a great job of for people with neurologic illness. In the case of Parkinson's disease, only about 20% of people die at home. The rest die either in the hospital, actually the majority die in a hospital or in a nursing home. And so we can absolutely do a better job of helping people around the time of end of life. And lastly is high rates of complex bereavement. So even after somebody with Parkinson's dies, their spouses are actually at higher risk for having complex bereavement because they've been losing their spouse one day at a time. And the ongoing loss, particularly when people have dementia, can be very difficult for families and care partners. And there are gaps in our current model of care. So as I mentioned before, we don't do a great job of recognizing and managing non-motor symptoms. Advanced care planning, which is helping people to prepare for the future, also getting paperwork in place, healthcare proxy, power of attorney. We oftentimes don't do that in a timely fashion. As I just mentioned, there's high rates of hospital deaths and facility deaths that I think are actually preventable, that we could have those happen at home and that we can prevent caregiver burnout if we intervene earlier. We are not systematically and routinely paying attention to psychosocial or spiritual issues. We are not routinely and systematically assessing, supporting, and providing resources for family and care partners. There are institutional barriers. As one example that came up today, in the United States, hospice does not cover physical therapy. And while that may make some sense for people with advanced cancer, for somebody with advanced Parkinson's, physical therapy may actually be helping them with control pain or other things like that. Nursing homes oftentimes don't do a great job for younger people with Parkinson's or Alzheimer's. And neurologists and palliative medicine specialists aren't being taught neuropalliative care. And that's something I'm doing a lot of now, is trying to get neurologists up to speed on palliative care skills and to get palliative medicine doctors up to speed on some of the intricacies of neurologic illnesses. Palliative medicine, I believe, is the future of medicine. I know a lot of times when we see these talks about the future of medicine, it's about robots, or it's about big data, or machine learning, or genetic programming. But I think the honest truth of it is that if you look back at the last 20 years, what really is happening is that medicine is becoming increasingly patient and person-centered. It's much less paternalistic than it used to be. Palliative care is essential to achieving the goals of medicine. And when people looked at what are the goals, is to relieve pain and suffering caused by illnesses, the care and cure of people with illnesses that cannot be cured, and the pursuit of a peaceful death. And these are all things that fall squarely under palliative care. It also ties into what's been called medicine's quadruple aim, which is that we want patients to have a better experience. We want to reduce the cost of healthcare, which is a huge issue in the United States. We want to improve population health, by which we mean healthcare outcomes in general. And we want to increase the joy in practice and prevent clinicians from burning out. And again, I believe that palliative care is essential to achieving all of these goals. This is a model of kind of our current state of affairs for Parkinson's disease. So we have a neurologist who is caring for the patient. They're helping with motor symptoms like tremor and Parkinson's medications. They're about half of the time, this is what studies show, helping with things like pain and depression. They may have a primary care doctor who's helping with other illnesses like hypertension and high blood pressure, diabetes, helping with other medications, maybe helping with nutrition. Nobody is looking out for the caregiver. And it's really up to the patient and the caregiver to take care of everything else themselves, to do advanced care planning, to do spiritual needs, to plan for the future. And what we see in our current state of affairs is that motor symptom control is good when people have a neurologist. Non-motor symptoms are fairly controlled, and everything else we do a pretty poor job of. That's really what our evidence shows right now. This was a model that we came up with for a grant that we just finished. And with this model, we have an interdisciplinary neuropalliative care team that is filling the gaps. So we have a physician who's really focusing on non-motor symptoms and honest discussions around prognosis, a nurse who's helping with nutrition and home care and advanced directives, a social worker helping for the care partner support and finances, a chaplain helping with spiritual and emotional well-being. And our hypothesis was that this model of care would provide better patient quality of life, better caregiver outcomes, better non-motor symptoms, that we would basically be doing a better job across the board. So we did a trial. We did a randomized controlled trial of 210 people in University of Colorado, Alberta, and San Francisco. And people in the intervention group met with our team every 3 months. And people in the usual care group saw their neurologist, their primary care doctor, and whatever else they did, they were free to do. We didn't stop people from seeing a social worker or getting counseling. What we found, and hopefully you can see the arrow here, is that quality of life was better for people getting palliative care. And it was better even 3 months after we started the trial, and it stayed better for a whole year. And what we think is driving that in part is that people had better symptom control. People also had better spiritual well-being. For care partners, there was a difference at 6 months, and that difference actually got greater. This is a measure of burden, so higher is worse here. And you can see that over time, care partners in the usual care group were actually getting worse and having more burden, and people in the palliative care arm actually showed some improvement and less burden. And I believe if we continue to follow this out, that those patterns would continue. Part of this could be that people with more severe disease, and this is a progressive illness, get more benefit from palliative care. Part of this is that some of our care partners shared with us that they didn't feel like they could take care of themselves until they knew that their patient was well cared for. And so that could be that there's a delay here, that once the patients were doing better, that then care partners were able to focus on themselves. Other things that we found was that symptom control was far better in palliative care, that motor symptoms, interestingly, were far better, despite not having any changes in motor medications. And I think this is because people were more engaged. Spiritual well-being was better. Caregiver spiritual well-being and anxiety were better. So across the board, I would say it was a very positive trial. And when we talked to people, did qualitative interviews, that people in the palliative care arm said that they felt seen and heard as individuals. They felt like they had a roadmap. And they also felt that even though some of the conversations they had were difficult, that they were important and that they opened up new doors for them in their lives. So some common questions that come up when I talk about palliative care include: when should palliative care start? Who should get it? And can we afford to do palliative care? Let's say we agree that palliative care is the right thing to do. Do we have enough money and doctors and space to do this? So I would say now is the right time to think about palliative care. And I have a caveat for that, but this is from a book chapter I wrote. If you look at palliative care needs here, that they really start at the time of diagnosis. Sometimes they even start before you get diagnosed, and that it continues throughout the course of an illness. So if people lose the ability to drive, they need help with dressing, they're having accelerating decline, other symptoms, all of these things may be triggers to get additional palliative care, but there is no point in time where it's not something that should be considered. I think some of the confusion comes in if that we think about palliative care just as a specialty, that not everybody, including at the time of diagnosis, needs a palliative care specialist, but everybody needs a palliative care approach. And that ties into this next question, that really everybody deserves this approach. So we want everybody to have a diagnosis provided with skill and compassion, that have their questions answered about the future and their prognosis, to have emotional and spiritual concerns heard and addressed, to get anticipatory guidance and advanced care planning, to have invisible symptoms like non-motor symptoms addressed, and to have family and care partners get care. So again, I don't know that everybody needs a palliative care specialist or needs to go to a special clinic, but I think everybody does deserve this type of approach and this type of philosophy. The indications for specialist palliative care, like the special clinic I started at Colorado, or the one I'm starting here in Rochester, or hospice care, these are some of the questions and some of the red flags that make me think that somebody needs more than just a palliative approach. So if people are getting towards the end of their life, something called the surprise question, would I be surprised if someone died in the next year? If a patient or family is experiencing significantly reduced quality of life or distress because of illness, maybe a good time to bring in a specialist. If people have very significant concerns or worries about the future, things that are keeping them up at night. If people are struggling with difficult to control symptoms like pain or fatigue. If there's significant mood, behavioral, or emotional issues. If there's significant spiritual, existential, or communication concerns, including communication issues between a care partner and this patient. Those are all reasons for talking to palliative care specialists or bringing in a counselor or kind of increasing the level of support. So those would be kind of the who gets that next level of support. And how can we afford to do this? So we don't afford to do this by having everybody get a 3-hour visit with a special team. The foundation of this has to be, and if we think back to that 3-legged stool, is that neurologists have to take ownership of this issue, and that neurologists are really going to have to step up to provide more primary palliative care. Community and advocacy groups are essential. I thank the Parkinson's Foundation and the Finger Lakes support group for having me speak today, and I apologize for accidentally double booking myself. But I think getting the word out, support groups are usually important. Involving, activating, and listening to patients. And this is one of my angles actually with this talk, is thinking about this as a grassroots movement. And I think as patients and families demand palliative care services are going to increase. We need to advocate for value, not just cost and cost savings, but both are important. By value, I mean getting what we pay for. When somebody dies in the hospital, it can cost $100,000 or more a day for care that they don't want and care that's actually traumatic to them and their family. So that's very low value care. High value care could be seeing a palliative care team early on and getting a roadmap. And there's been a number of studies that show that palliative care actually has net cost savings because we avoid care that's unwanted. Integrating specialist palliative care when it's needed is important, and pushing for policy change and resources, I think, is going to be important in terms of thinking about the long-term game. So what are the components of neuropalliative care? This is a quote from Dame Cicely Saunders, who's really the mother and the founder of the modern palliative care movement. You matter because you are you, and you matter to the end of your life. We will do all we can, not only to help you die peacefully, but also to live until you die. And I think the key pieces there, the key ingredients, are really hearing and seeing people. One of my favorite questions to ask in clinic is, tell me about your life before you had Parkinson's. Because that gives me a lot of clues of how we can make life better now that you do have Parkinson's. And then this last piece, to live until you die, I think is very important, that it's not just about a comfortable death, but really about living every moment that you can until then. A big part of palliative care is serious illness communication. These are things that we are working on training student doctors and residents and even people in practice. How do you give bad news in a way that is compassionate and helpful and skillful? How do you discuss prognosis, including discussing that you don't have a crystal ball, but still being able to provide somebody a roadmap? Being able to understand somebody's values and goals and to mesh treatment plans with that individual's goals. Working with difficult emotions like grief and anger and guilt and loneliness, and helping people to empower them so that they have a sense of choice and control, despite the fact that they have an illness that they certainly never wanted or chose. Other things that are part of the skill set, and that you don't have to be a palliative care specialist to do, is advanced care planning. So that would be things like filling out a living will or advanced directive, having conversations about what you would want or not want, and what's most important to you in the future. Being able to support care partners and family members, or at the very least, to check in with them and get them to people who can help them if they need it. To address non-motor symptoms. And regarding this, I'll bring this up again, but part of this is on patients, to bring them up, that you have to come in with a checklist, that somebody can't tell you're having fatigue unless you tell them. Attending to psychosocial and spiritual challenges. Recognizing when people are nearing the terminal phase of their illness so that they can be prepared. Some of my work is with people with brain cancer, and in that clinic in particular, I think it's really important that if people have 6 months or a year to live, that we do whatever we can to make sure that that's the best, most meaningful year of their life, rather than a meaningless journey of going in and out of the hospital. And lastly is referring to people to hospice or specialist palliative care in a timely fashion so that they get the care that they need when they need it. I think it's important, excuse me, and has been a kind of a surprising gift to me in doing palliative care of what I would call positive medicine. So this idea of helping people to live until they die, not just to survive. And so we can work with people on building resiliency. This includes both care partners and the patient. Helping people with self-care, restoring choice, control, and meaning. Finding opportunities for joy, love, and meaning throughout, for instance, the skydiving story, but even simple things, encouragement to eat your favorite food every day, encouragement if you love the outdoors, to take a drive or spend a day in nature, even if you're not hiking or doing things the way you used to do it. We may not be able to control how much time we have, but we can control what we do at that time. And that's something that I always try to reinforce with people who I'm seeing is are we really making the best of our life? And that's something that unfortunately we can't get back. These are some ideas and suggestions to help your healthcare provider be a better healthcare provider. So if you bring in a checklist of issues that you want to cover, like pain or constipation or depression, it makes it much less likely that that doctor or nurse practitioner is going to miss those things. So sometimes people don't bring it up because they're busy or they're not in the habit of checking it. But if you bring it up, a lot of times they will address it or they will make sure to find somebody to help you. You can be the person to start important conversations. Your doctor may not know that you want to talk about prognosis or about the future, and you can be the person who's brave enough to start that conversation and to let your provider know that you're strong enough to handle this. You can share with your providers what's most important to you, so that that can inform their care decisions, and you can share with them, let them know that, hey, by the way, I used to be a doctor or a social worker, or I used to run a company, and this is the way I want to live my life. You can state your preferences for care and medications. I've heard from a number of patients that they don't tell their doctors about certain symptoms because they're afraid that every time they open their mouth, their doctor puts them on a new prescription. So some of these things you have control over, and you can take a more active role in your own care, or as a care partner, a more active role in advocating for your loved one. So connecting to the neuropalliative care philosophy, this is a quote from John Kabat-Zinn. So extending the reach of our own heart, let us live in the world in ways that embody greater wisdom and compassion, loving kindness and equanimity, and ultimately the joy inherent in being alive. And again, to me, this encapsulates what we are trying to do with neuropalliative care. So hopefully at this point in the lecture that you might find some ways that palliative care ties into important values to you. That might be being comfortable, spending time at home with family, making time for joy, love, and meaning in your life, being seen and heard by your healthcare team, having tough conversations now to make it easier for yourself and for your family later, being a role model to family and particularly to the next generation, to your children and grandchildren in terms of grace, courage, and wisdom. One of my favorite questions that I learned from a chaplain is asking people, how do you hope to grow through this illness? And I love that question because it really restores choice and the sense of freedom and allows you the opportunity to continue to grow despite having an illness that you never wanted. There are a number of opportunities connected to palliative care. There are research studies that are happening. This is something that can be brought up in support groups. Novel care models you can advocate for at your local university or center. Opportunities to educate the public as well as physicians, service. So definitely something I'd be happy to talk to people more about. And lastly, how do we integrate neuropalliative care into practice? How do we make this a new standard of care? To know and not act is not to know. So how do we put our money where our mouth is? We have just gotten a new grant with the Parkinson's Foundation, funded by the Patient-Centered Outcome Research Institute to do just this. And so PCORI funded our first study, which I presented those results that showed pretty convincingly that palliative care is a good idea for Parkinson's. And the Parkinson's Foundation and PCORI agreed, and they said, let's take this to the next level. Let's make this a new standard for all 47 of our centers of excellence across the world. And so how we're going to do that, we've already started talking to each of the centers of excellence to craft individualized plans. We're going to operationalize palliative care around 5 things that we can do and measure, namely checking for non-motor symptoms, doing advanced care planning once a year, checking in with patients on grief and loneliness and guilt, referring people to specialist palliative care and hospice when needed, and to provide training and coaching to the centers of excellence so that they can do this. We know that this is not going to happen overnight, but we do believe over the next 3 to 5 years that we could really move the needle to making this the new standard for Parkinson's care. These again are the 5 pillars that we feel like should be the standard. And this is what we are going to be holding the Parkinson's Foundation Centers of Excellence accountable to when they're going up for funding again, is seeing how well they are able to live up to these 5 pillars. So annual advanced care planning, providing caregiver, care partner assessment and support, screening and managing non-motor symptoms so they don't fall between the cracks, screening and managing psychosocial and spiritual issues, and referring to specialist palliative care or hospice as appropriate. As part of this grant, we wrote this grant actually over a year ago, and the world is a very different place right now. So we got a second grant that took our original grant and updated it for the COVID era. And that included bringing in telemedicine and telepalliative care. It included talking to people, including patients and caregivers, about how COVID and telemedicine has affected their life, to make sure that we incorporate that into our new model. And lastly, like we're doing today, to do training and coaching and education remotely rather than in person. So to sum up, and we have about 15 minutes for questions, Neuropalliative care is about living as well as possible for as long as possible. Our goal is to improve the quality of life of people living with neurologic illness at any point in their illness. Palliative care needs are important drivers of quality of life, and they're not often well met under current models of care. Neurologists, not palliative care medicine specialists, but I think neurologists are really going to be the key to improving palliative care for Parkinson's and improving outcomes. And as was shown in our study, palliative care absolutely does improve outcomes, in part because of better communication, in part because of other skills like pain management. Neuropalliative care can enhance your life with a serious illness. So as a patient and as a care partner, you can and should be part of the palliative care team, and you can drive some of those conversations. And that ties to this last thing, is that to get neuropalliative care when you need it, you have to be that voice and demand it. And I'm hoping, that as a community, that the grassroots support from patients and families, I really believe that's going to be a big driver of whether or not we succeed in the next 3 to 5 years to make this part of routine care for Parkinson's. So with that, I will stop my share and open things up for questions.
Hi. First of all, thank you so much for that presentation, Dr. Kluger. That was a lot of information, and we really appreciate it. So I have a few of, I actually have a few of the same questions. So I'm going to ask this one first. People want to know specifically about how to bring this up with their doctor. That's uncomfortable for a lot of us. You being the expert, I love that you provided those phrases, those starting point phrases. And I was going to see if Danielle, if you could share those in the chat section. Why do you think that providers might be hesitant to help people get, or do you think they are hesitant, and why might they be hesitant to help with this care?
Yeah, so I could, kind of provide a little bit of an inside scoop there. There are 3 things that are hard for providers about this. One part of it is that providers often have the misperception that if I bring up advanced care planning, or if I bring up hospice, that it's going to destroy hope. And if it's done in a way that's skillful, it actually doesn't destroy hope. People actually feel less anxious, they feel relieved. But for providers who aren't used to doing this, that the providers are anxious that they're going to destroy hope. Providers don't like providing bad news. They don't want to tell people things that may hurt them. And they may not have the skills to feel comfortable doing that. So as a patient or as a family member, if you open up that conversation and give them permission to tell them about it, and let them know, that I'd like you to tell me more about what my future with Parkinson's looks like. And I know some of it may be hard for you to say, but I really want to hear it. In some ways, you're letting them off the hook. And it's one of the things that I actually really enjoy about palliative care, is how it brings people together. But oftentimes when I have a conversation with a patient and a family member, I'm bringing up something that people really want to talk about and they're really afraid to talk about. And so you can do that for your healthcare provider. And more often than not, I think they will be appreciative for it because they also have difficulties with these conversations, just like anyone else does.
Right. Yeah. Very good point. So I'm just kind of thinking, walking through this visit, we did talk a lot about the caregiver and the role of the caregiver, which I love, again, because to your point, it affects the caregiver, you know, as much as the person with Parkinson's. So what is the role of the caregiver in that visit? You know, I know there's always concern about, you know, diminishing someone's autonomy or marginalizing someone. What do you think, have you learned in your practice, is the best way to involve the caregiver?
Yeah, it's a good question. And I guess with a lot of these things, it kind of depends on where people are at in their illness. You know, I think it's important, and I've heard this from care partners, is that if somebody is able to speak for themselves, that they should. And that we don't want the care partner to feel obligated to be a spokesperson. And we also don't want a care partner to speak for somebody who is perfectly capable of speaking for themselves. They're just slower at it or other things. You know, later in the illness, the care partner may have a role of even speaking separately with the physician about, this is how things really are at home. You know, I know my husband says everything's fine, but he doesn't have a great memory, and this is what's going on, or there are safety concerns. So sometimes the care partner will have to be kind of more of a fierce advocate to make sure that the physician really knows what's going on. The third thing I would say is that care partners, and this came up in a lot of our qualitative interviews, also need to let people know when they need to be seen and heard as an individual. And it was heartbreaking for me when we did our interviews with care partners, but for a lot of people, taking part in a research study and doing an interview, that was the first time anybody, physician or family member, had spent an hour to hear how things were going for them. And so it's heartbreaking to me. And again, it's something that it would be great if as a system we got better at it. But until that time, you know, sometimes the care partner needs to speak up and say, I'm feeling really overwhelmed here. I feel like I'm burning out. What can we do to get me some more help?
And we also talked about this general idea of pain management. And what I really love, especially because it's the holidays, right, is that you talked a lot about the total pain, including spiritual pain. Right now, that's very relevant for a lot of people, especially for those with chronic disease. So I think that's a little bit new for most of us, the idea of spiritual care being medical care. And so can you just sort of give us some more information on those sorts of services and its role?
Yeah. So this idea and this term total pain, that came from Cicely Saunders. And it's kind of tied to what is a burgeoning movement of person-centered care. So, I mean, one way that medicine has devolved and then evolved again in the last century is that, you know, around the turn of the last century, you know, into the 1900s, we got much better at diagnosing diseases. And we developed x-rays and MRI scans, and we can look at the genome. But curing a disease and taking care of a person are two very different things. And so over the last, I would say, 40 years, and in part the palliative care movement has been pushing for this, is recognizing that we need a care for people. And that when we look at suffering, suffering is not just physical pain. Suffering is also emotional pain, it's grief, it's loss, it's loneliness, it's guilt. It's you know, feeling demoralized and hopeless. And so that's really a core part of the palliative care philosophy. And it may be helping people with resilience. It may be connecting people with a chaplain or a psychologist or a social worker. It's part of the reason why palliative care is such a team sport, is that if we're taking care of a complete person, not just the illness or disease, Parkinson's, that we need a lot more skills and a lot more people in our corner.
Yeah, a lot of these questions that I'm getting are actually about insurance coverage and, you know, accessing that. And I think I think it is made a little bit more complicated by your point that palliative care is a skill set. And so, you know, knowing what providers to get to and how to access those, and the insurance coverage is coming up a lot. If you could comment on that.
Yeah, absolutely. So I'll start with an easy thing, which is that hospice is covered by Medicare, Medicaid, and all insurances. Palliative care is covered to a degree. So, you know, I do palliative care and I accept people's insurance. What is not covered, and this gets into kind of a bigger thing of where we need advocacy, is social workers and chaplains and other members of the team aren't always paid for. And so part of the reason I moved actually from Colorado to the University of Rochester was I wanted to be at an institution where I would get more support from the institution for doing those kinds of things. We are working on, because it does save money, of working with insurance companies and Medicare and Medicaid for kind of novel payment models where they might pay the University of Rochester, say, $2,000 per Parkinson's patient, and we take care of all of their care. And then we decide what's best to do with that money. And that might be that we have more social workers and chaplain, and we work to try to save money by keeping people out of the hospital. So I think that's going to be an evolving thing. But currently, you can see a palliative care specialist or hospice, and it's covered by insurance.
So a little bit more on that, a comment about the role of policy. So yes. I know just in the past year or so, we've seen the lift on the 12 limit visit for physical therapists, for instance, you know, go through. So what can we do as people with Parkinson's, caregivers, loved ones? What can we do to help advocate for palliative care to become a standard?
Yeah, that's a great question. And there's a number of areas that I think voices could be heard and things pushed for. So around hospice, people with neurologic illnesses are actually much more likely to be discharged from hospice and less likely to be taken on. And part of that has to do with that neurologic illnesses are just different than cancer. You know, in cancer, chemo works or it doesn't work, people die. With Parkinson's, you know, people can survive at a pretty low level of function for quite a while. And people at that level of function might still need physical therapy and occupational therapy. So I think we need to update our hospice laws to meet the actual needs of people with Parkinson's and Alzheimer's and things like that. And then secondly, for palliative care, is I think we need to kind of advocate for value in healthcare. At the end of the Obama administration, there was a plan for continuing the Affordable Care Act to really push for more progress in that area. And unfortunately, things were just kind of put on hold. I don't know what healthcare is going to look like with Biden, but I think, again, patients and their family members can absolutely advocate for value and can say that, you know, we think it's important that people with Parkinson's have access to team-based care, that we include psychosocial and spiritual support as part of what's covered by insurance. You know, so those are things that I think a strong patient voice and a strong community voice, you know, could absolutely help improve care.
So I think this might be our last question, but people wanted to know a little bit more about that PCORI study. So you shared a few of those takeaways, which were living better and living longer, which are incredibly motivating reasons to seek this care and use this care. What else did you learn? Is there anything else that we should know about that study?
Yeah, and I think I might have given you, I don't know if we posted it as a link, but you're welcome to read the full study. You know, but I think those are the big takeaways from it, was that patient quality of life was better, caregiver burden was less, symptoms were better managed, people felt seen and heard, spiritual well-being. We didn't follow people longer, and in fact, one of the way the study was designed, we actually excluded people who had urgent palliative care needs because we felt like it wouldn't be ethical. But our sub-analysis would suggest that those were actually the people who might benefit the most. So if anything, even though it was a positive paper, it would have been even more positive had we included all comers. So I don't know if there's other specific questions, but I think it does provide pretty overwhelming and compelling evidence that this can really help us in terms of achieving our goal of improving quality of life for everybody affected by Parkinson's, clinicians, patients, and family.
Well, great. Again, thank you so much, Dr. Kluger, for joining us today. We really appreciate it. We also, of course, want to thank all of our attendees on Zoom and on Facebook Live. We want to thank our program sponsor, Light of Day, for their support. I want to mention we had a few questions. Today's session has been recorded and it will be archived on the Parkinson's Foundation YouTube channel within a few days. You'll get that link automatically. So you'll have all that information today within a few days. We also have a comment thanking you again, Dr. Kluger, for your presentation today. So if you had a question today that we didn't get to, please reach out to us. Call 1-800-4PD-INFO, email helpline@parkinson.org. You can use that same contact information to order our free resources. So all of those books and the hospital safety kit that we mentioned. Thank you again so much for joining us today. Happy holidays to everyone and stay safe.
Take care. Thanks.